Good afternoon, everybody, and thanks for coming back. And I hope you've had a nice lunch and an opportunity to interact and connect with people and have some good discussions. So we're here for our afternoon session on our event today. And the afternoon session comprises maybe three main pieces. We'll have a plenary, we'll have a panel discussion again, and we'll have a wrap-up from our rapporteur. And I didn't mention him this morning, I should have, because he's central to this whole process. He's the initiator of it, and that's Dr. Fergal Lynch. But I'll introduce Fergal later on and just say thanks to Fergal for his involvement in this important work. So we're going to kick off with our plenary speaker, who is Muiris O'Connor, and Muiris has promised me he's going to stick to time. So where is he? Yes, he's there. There he is. I've no fears in relation to him. I suppose it's nice when we have somebody who is a graduate of the university, who's working at the level he is within the Department of Health. He's an Assistant Secretary in the Department of Health, and he heads up the R&D and Health Analytics Division. And again, looking at the themes that we're interested in the Institute and in this dialogue between government and academia, his responsibility for evidence-based approaches to policy and the promotion of research and innovation in Irish health and social care. His responsibilities include health information engagement, health services reform, and so on. And as I said, he's a graduate of here, which is nice. And also, he's somebody who worked with one of our esteemed, recently retired professors here, Professor Eamon O'Shea, who's one of the founders of the Institute. So it's a nice tie-in. So I won't, without further ado, just hand over to Muiris and look forward to what he has to say. So thank you, Muiris.
Thanks a million, John, and good afternoon, everybody. Just to say, I'm really enjoying the event, and the morning was fantastic. I want to thank you, John, Caroline, Deirdre, and all your colleagues here in the university, and Barry Vaughan in the Department of Taoiseach, who kind of nabbed me for this speaking slot. So I very much welcome being here, and I've really enjoyed the day. I have 41 slides, John, but don't worry, I will keep to. A lot of them are pictures, and I wanted to, I have quite a few staff, and they're all brilliant, and I got a few people active just in sort of getting me sort of ideas for this presentation. And Hilary Lovejoy is in the audience, and Andrew Hannigan in particular helped me, and I got way more material than you're seeing here. And actually, when it comes to things like public and patient engagement, I felt like I couldn't really do the stories justice. So in the first part, I'm going to give an overview just to reflect the extent of sort of public and patient engagement that is now included in health service development, health service improvement, and health policy development. And then I'm going to lean in on my own experience for most of it and offer some reflections in the end. So that clock isn't ticking away there, so it just maybe if that can be started, I'll keep to time. So first of all, in terms of the broad range, and there was really loads that came in, I just have a subset of examples of, as I say, the extensive use of engagement in health and social care. And Dilly O'Brien, my colleague, is in the audience here and leads on the Women's Health Initiative and the Women's Health Task Force. And this it was created in 2019 and has come on strong in the meantime. It absolutely locked in on understanding the experiences of women and girls in terms of the Irish health system. It had a real commitment to listening. There was a phrase at the outset, we've kind of dropped it, but radical listening was used. Just kind of to shake us up and kind of make us appreciate that the health service wasn't always hearing when we were engaging. And we've kind of dropped that term, but I think it was good to kind of unsettle us and have us kind of in a listening mode. There's been a kind of a very deep involvement with a women's health task force with patient and representatives, and there's a listen, invest, deliver, repeat, short cycle action plans, and I think it really has made an impact It's kind of brought us above, and very consistent with policy more generally, it's brought us above the kind of incidence of acute care that we kind of tend to organise around, to look at the life course and keeping people healthy and well through the life course. And you can see that with the initiatives now and the support through menopause and endometriosis and lots of other areas. And we continue to benefit from that deep engagement and the reflection and that cycle in women's health. The mental health services, like I say, I got about 8 very comprehensive slides, and it really is a service, I think, that is committed to co-design and deep engagement with patients, understanding user experience. There's a lot of phrase, and again, my slides can be shared by the organisers afterwards. The co-production, active involvement of citizens and service users in sharing the vision. In suicide prevention, there's training now that's actually provided in conjunction with people with lived experience of suicide and suicide prevention. And that's really enriching the service and making it more relevant to the people who need the service. Nicotine inhaling projects, just for the diversity of kind of engagements that we do. Our tobacco and alcohol policy colleagues engaged in a consultation, a public consultation on how best to approach regulation of tobacco and nicotine inhaling products, vapes basically. And this was interesting because we got a massive amount of inputs into this online engagement, many of which were generated by the industry themselves. They were kind of offering benefits for young people to input favourably in favour of vaping and all that, and kind of made a big effort to distort the process. So that had to be managed carefully in us drawing the inferences and balancing that what came through. Like 90% of the 15,000 were people who used vapes regularly. So we just had to balance that with the public health advice. The citizens' assemblies, they were mentioned by the new keynote speaker from New Zealand, and our position as a poster child, I think was the term she used in these. And she mentioned Alistair Campbell, and I don't know, nerds like politics, and Rory Stewart works on a podcast, The Rest is Politics, with Alistair Campbell. And my God, does he love citizens' assemblies. He thinks they're the answer to absolutely everything. And I have mixed feelings about them. I think the methodology is really interesting. I think they're really, really enriching. But I don't think any have delivered quite as concretely as the first one on abortion. Like for a public servant such as myself, this was a wonderful outcome, a really difficult issue, delicately balanced. I know we mightn't all be happy with all aspects of the outcome, but it gave the political system a sort of a focal point. It took the tension out of a very, very difficult and complex issue, and I think landed in quite a good place. The other citizens' assemblies, I mean, I haven't read the outputs from them all, but they haven't been as concrete. The one on drugs, for instance, has 36 recommendations, and I'll read you the first one just to give you a flavour of it. So, recommendation 1, the state should take urgent, decisive and ambitious action to improve its response to the harmful impact of drug use, including implementing necessary legislative changes. And it's kind of like, thanks, like that's not much help for the public servant in a way. It's almost you should do the right thing with the right balance of consideration. So, and I'm not saying it absolutely enriched our understanding of drug use and drug use policy and international best practice. It did all that, but I think the kind of total result that was delivered almost as a legislative proposal in the first one, I think hasn't really been reached by the others. But like I say, we're famous for it, and it is a very enriching thing. And in the health arena, at smaller scale, not the fully government-sponsored ones, but IPOSI, the patient representatives in health, have run citizens' assemblies on the use of AI in health, on e-health and the rollout of digital health records. And again, they've been hugely hugely valuable. So I want to be balanced in my sort of comments on that. So, yeah, like I say, there was loads more I could have drawn from, and I think Joe is there, there's others from HSE. There really is a huge amount of patient and public engagement, very sincere commitment to it, a real recognition of the value of it in the HSE and in the department. And in my own experiences, as John says, I'm a student of Galway. I stayed in Corra Village for the first year. And I'm kind of, I suppose I'm a nerd by trade, really. I'm a statistician. I did Soc and Pol and philosophy here. I did history in first year. And in a way, without sounding too grandiose, in terms of my own experiences, I have my love of history for kind of a depth of analysis, sociology for breadth of analysis, statistics for insight, and the philosophy to help me make some sense of all that. And I suppose I want to speak, like I'm deep inside the department, and like I say, I don't do the public engagement. I mean, I meet people when I'm out and about, but I'm not in the directly exposed to the patients and the public in the way colleagues are. But I want to talk, maybe building on the handbook that was launched this morning, on the importance of enriching public engagement with the evidence, the emphasis on evidence. And I regard myself as being person-centred in my approach to policy and service development through a focus on the full population. And I'll try bring that out with some kind of slides here. So one of the things I was doing, and I was digging back on all the slides I've ever done, kind of preparing for this, but I found this is from work I did about 2015, and I can't remember what I was doing, but I was looking at the full Irish population since independence, since we were founded as a state, and I was kind of thinking, you know, God, there must be tens of millions of us must have lived and died, you know, since the foundation of the state. And this is as of 2012 now. But this is the numbers of births every year since 1922. And to my surprise, when you add up the number of everyone ever born in Ireland since independence, it's only 6.25 million, which is kind of, for me, that was surprisingly low. And the 6.25 million is up to now. It was 5.5 million when I produced this slide in about 2015. So I had it in the tags there, and don't worry about reading them, but it was the ages that people were now, or in 2015, at that time on the basis of a year of birth. And it shows how new a country we are. Like, we're 5.2 million people now, so we now are the majority of people that have ever been born in this country. So we're a bigger part of our history, and we're a bigger part of our society than we presume, I think, at times. And then in terms of how recent history is, and forgive me, a real tangent here now, but I want to go back to October 2005. And like I say, it was a very exciting time in my own life. My eldest daughter, Roisin, was born September 2005. And I've always been a news hound. I love current affairs as well as history. I kind of regard them as the same thing. So October 2005, on the 14th of October, Roy Keane retired from international football after, I won't go down there, a lot of saga. Liam Lawler was killed in a car crash in Moscow on the 22nd. On the 25th, the Ferns report came out, just kind of pulling us right back into an Ireland, well, not so far back actually, but unearthing some very uncomfortable child abuse by the church in Wexford, I think it was, with the Ferns report. But on the 24th, Rosa Parks died on the 24th of October 2005. And I literally couldn't believe it, because, like I say, love history, knew all about Rosa Parks, hadn't heard from her in ages, thought she was black slave history and reached so far back. But it really struck me, my own child overlapped in her life with Rosa Parks, whose life, like, she was 42 when, there she is as a young girl, it's hard to, she's probably a teenager there. born in 1913. So she was 42 years old when she declined to give up that seat in the bus in Montgomery, Alabama on the 1st of December 1955. And there's a mugshot of her. There's her fingerprints. And look at this is funny. That's the bus that she refused to give up a seat on, which is now in some museum in Alabama. So it's a bit funny, but it's just, that really sort of gave me that sort of compressed sense of history. And like I say, literally like the first thing where there aren't as many Irish people out there, you're a bigger part of Ireland than you think, you're connected closer to history than you might think as well. And actually just show how fast history moves. 1st of December 1955, she was arrested. And a year, 3 weeks later, she sat as fully entitled to sit. So they eliminated segregation in the Montgomery transportation system within a year. So yeah, so my kind of passion for population statistics is motivated by sort of patient engagement, by all of us as individuals and understanding the conditions, and also aware that, you know, in the circles that we work in, we don't always hear from the people who don't have a voice. We probably definitely don't hear people who don't have a voice. And I think that kind of statistical lens, complemented with the sort of expertise that I really feel in the other contributions around patient engagement, is a vital combination. There's De Valera kind of looked deep into my chart, but I was channeling my inner De Valera kind of with that idea. Not that I'd know without the statistical evidence like De Valera, but you know, I don't. So yeah, the grids. I think that the national statistical infrastructure, which Liz has played a big part in sort of strengthening over recent decades, is just phenomenal. And I think it helps us to lean into that. I think health, we overplayed how precious and sensitive and personal health data is, and kind of have kept it away from the wider sort of the use of evidence for public service, and I think it's to our detriment. And I think one of the things I've sought to do is plug health right into the national statistical infrastructure and into the PPSN, into AirCode, just to deliver a proper service to, like I say, we're just 5.2 million people, we're smaller than Manchester. And I'll talk soon about the health regions reform. So population health statistics, and there's a load of very good surveys there, very rich, deep surveys. And actually I think one of the best and most sort of fruitful ways of engaging with patients and the public is actually to sort of share in an analysis of emerging evidence like this, and sort of seek to understand it in a sort of a co-produced way. So health regions reform, as John says, it's a big part of my work, and it has absolutely been driven by public engagement. And this is the as was. I think this is just pure chaos here. I can't even explain this to you. But over here is hospital groupings that were sort of determined in 2013. And they really didn't observe any geographical coherence at all. There's some crazy stuff going on with hospitals there. And it's a real example to me of a complete disregard for the person-centered approach to health service development. The networking of hospitals was done in a way I actually don't fully understand, but it was something to do with medical networks or some of the larger hospitals trying to grab smaller hospital campuses as into their zone of influence. But it led to a really, really incoherent group of 6 kind of regional ones and the Children's Hospital. And then afterwards, and the policy was right at the time, the policy was about integrated care, but when the hospital groups were kind of agreed at political level to look like this, then there was very little the HSE could do to wrap proper population-based integrated care around them. And there was 9 community health organisations, kind of 1, 2, 3, 4, you see them around there. And the hospital groupings interface with these regions was just chaotic. So the kind of integrated person-centred care, where you might start with your GP, be referred to a hospital, need a community facility, it just amounted to so much sort of organisational boundaries that it was completely incompatible. And to their credit, the politicians of Dáil Éireann in, was it 2015 or 2016, I can't remember exactly, but there was 7 months after an election, an uncertain election outcome, where they just were trying to add up a government. I think that Fianna Fáil come in so kind of supporting from opposition ultimately. But they assembled a committee on the future of healthcare in that interregnum and delivered the Sláinte Care strategy. And I must say, I know we talk about the patient engagement we do, the politicians that we elect are absolutely committed to representing the public, and I think they generally do it really, really well. And when they work together like that, that created a huge sort of platform for us in health. I've been lucky, I think, to work in the Department of Health in an era when there's kind of political consensus. Now, this consensus is arrived at by kind of an altitude that they went up to, which kind of goes quite high level, but it has been hugely helpful. And there was 20 years before that where whoever was in opposition were absolutely promising to tear down whatever the government were trying to set up in health. So that was really, really chaotic and uncomfortable. And I think there's it's a big part of public engagement. And here's a great slide put together by Andy, just to capture the level of public engagement in the reform programme. So we had patient partnership baked in. Now this is me with a team in health, but a huge amount of people in HSE as well, pushing forward with this reform. And in fairness, it resurrected ideas and commitments to integration and population-based approaches that were really live between 2000 and 2010. That kind of hospital group report just flew in from the side and kind of threw it all up in the air and lost us a decade, I would say. But there's staff and service provider engagement, professional expertise through a Health Regions Advisory Group, political engagement, the Joint Oireachtas Committee on Health. Again, being in there was really, really interesting. It wasn't getting beaten up. It was often getting told, why aren't you delivering faster and what are the issues? We used to pull in the Joint Oireachtas Committee sessions in the Oireachtas, and they never made the news. They were too cordial to make the news almost. But we pulled them into the department for some of the technical detail as well. And again, just found them really, really, really constructive. So we did a consultation that was a bit weird. We determined these regions on the basis statistically. These are the regions that achieved integration with the minimum amount of disruption to existing services. They're the ones that align scientifically most closely with existing service usage patterns. They're the hospitals people go to anyway. I mean, it's all common sense. They follow the road networks. That's what people do. They follow the road into the hospital, the main hospital that's near them. And these have a coherence. They all have a cancer centre, at least one. They all have a maternity hospital. They all have Model 4s. They all have a section of other hospitals. And of course, they have their pharmacies, their GPs, their community organisations. So we consulted on, are these the right boundaries, and what do you think of the policy? And like I say, it wasn't a public consultation of enormous interest. They're just some of the criteria that we had done. But it was a hard one to hear. We had 230 submissions, 66 from organisations. This is May 2018. 66 from organisations and 164 from individuals. I read them all. The individuals weren't the public as such. They were actually, when you read them, they acknowledged, it was obvious, they were staff right across in the HSE, across the country, or in other parts of medicine, in chemists, in GP practices. And it was hard to hear, like they totally supported the proposed reforms. The integrated care, the integrated management teams, the connections across community, acute, GP and all that. But they absolutely had zero confidence in the senior management of the department and of the senior management of the HSE in delivering authentically on it. So it was really, like, this is not comfortable engagement, if you know what I mean. This was really difficult to hear, and it's something that we have sort of bottled up and sought to motivate us and keep us kind of straight now. And even, like, it was paused during COVID, and these regions have come in There's regional executive officers, there's management teams at regional level with coherent geographies, fixed populations that they know and that they're committed to and responsible for providing services to. So they're just some of the products, and like I say, the slides will be made available. So health information policy is another area of huge interest to me, and it's absolutely vital. In fairness, again, the Sláinte Care report recognised that integrated person-centred care required digital health rollout, summary care records for people, and sharing of information between different health services. And we made a mess of the GDPR and how we've interpreted it, and I do not have time to moan about that here. But there's a European health data space published in March this year. It is law, it's a regulation, so it applies directly across the 27 member states. It has a kind of a schedule of rollout. Now, don't worry about this, but it's just years. We're basically here. There's the years ahead of us where there's commitments, and I love how this is framed. This is real top-down, person-centred legislative policy, because the European law commits to each of us as European citizens that our governments will organise our health information in ways that connect it properly, represent it back to ourselves, deliver digital prescriptions, maintain records up to date, and then there's huge amounts, that's for direct care, and there's huge amount of value then in secondary care, for research, for innovation, for auditing, for assessing the effectiveness of services, the efficacy of medicines and all that. So there's a really, really exciting programme of work, and it's a huge benefit to us in Ireland. And I think we've often needed external sort of pressure like Europe to help us get over ourselves a bit on GDPR. Like I say, I won't start, but we 12 other member states have delivered all that we want to do in the next 10 years here under GDPR. That's all I'd say. Exact same law. So there, I'll move on. Health information practice. Those of you familiar with health will know just how fragmented it is. We have sort of pockets of excellence. We have like sort of some digital systems. We have an electronic health record in maternity, in the maternity wards of certain hospitals, but not in the full hospital. And we have all this kind of patchwork. And I suppose one of the things I want to throw out there, and I'm not blaming public engagement for the fragmentation. We have to own that as the managers of the department. But I do think there's interesting questions, because the patient representatives in health are often very motivated by a lived experience of one particular condition, and their ambition is often confined to a certain slice of the health service or a certain service in an area. And in a weird way, the ordinary person, nobody has come to me trying to push for those who have not yet fallen ill, if you know what I mean. There's people that are really locked in on services of a specific nature, and medicine, the way we organise medicine, with I think a rather bizarre amount of super specialisation, that works in a kind of a chemistry that I think amplifies fragmentation if we're not careful. So I can talk more about that in the Q&A. So what we want to do is, and the European Health Data Space and the Health Information Bill will help us lock in on the kind of every person. In the Health Information Bill, our impatience with our poor progress is reflected in the fact that in Section 3 of the bill, we've literally specified the categories of information that we commit to providing to all Irish people, or all people in Ireland, on their summary care record. And we hope that while digitisation, and we're hopeful of investment there, will take quite a while, that good use of the data, irrespective of the technology, will deliver value for us all as citizens and improved, more connected health services in the kind of 2 to 3 year time frame, while we kind of enrich then the digital systems that might improve it all the while. So building trust is absolutely vital. Observations. Yeah, I think I've reused. I think I used this slide in this room about 6 years ago. But in health, like I remember in education, where it was for much of my earlier career, like we had brilliant data from exams and all that. We had a good handle on it. But there was a lot of times in education, I had a very exciting roles of kind of filling gaps, like student engagement surveys and all that, and kind of try to fill gaps in our evidence base and then inform policy. In health, there's a blizzard of information, like beeps and bleeps, especially coming out of the hospital system. But it's kind of busyness metrics, it's not person-centered. So we have, and this is Dr. Howard Johnson, recently retired from HC, he told me when I started, we have lots of data, Muiris, but we have little information and we have less intelligence. And like you get that thing about statistics being deciphering signal from the noise. But now, without sounding too highfalutin, I recognise now it's not just about deciphering signal from all that noise. I want to shut down much of that noise. I think it's distraction and miserable ease, as they say. But it's about organising the noise in ways that deliver signal corresponding to what it is we value. And that's, for us in the department, our mission is to improve the health and well-being of people in Ireland. And I think we need to just sort of organise that noise, like I say, and this is our plan with the European Health Data Space, with the HSE app, with the shared care records that'll be done, responsible to organise that noise in ways that deliver value for people. Intentionality, I think, is hugely important, and I love this definition, kind of almost, it's kind of like a poster on my wall kind of thing, just an action performed with awareness, done deliberately, consciously, on purpose. I think that's so important. It's the golden rule for GDPR compliance as well, actually. Know what you're doing, be intentional, be purposeful. But I think it's a good thing for good public policy. So I had De Valera earlier on, so I wanted to balance my Civil War out things, but this is a letter that Collins wrote not long before he was shot. True devotion, he wrote to a friend, lay not in melodramatic defiance or self-sacrifice, but in steady, earnest effort. And I'm going to finish with Lemass, and I kind of, like I say, I love history, but I love the plainness of the English that our politicians spoke in the Lemass-Whittaker era, and you can see it here, and I know around the time of launch, yeah, so this was, I don't know, it was when he was announcing the convening of that team in 62, or if he was marking its report in 65, but the Investment in Education report, which is why you're all in college. So he called on his government to frame a development programme and set the targets which must be realised if our facilities are to be kept in relation to our requirements as a progressive national community. And I love that progressive national community sort of narrative. And just to finish, with 22 seconds left, and just to bring it back to that start, how much a part of Ireland we all are, and how new a country Ireland is. Like I was Googling there, different results coming from different AI systems. One said we were the 8th oldest democracy on the planet, but I think we're probably more 14th or 15th oldest. But I don't know how many countries, there are 200 countries on the world. But it's precious what we have, and I think we do have an authentic commitment to public engagement. I think our political system has to be respected as the key channel, and I do really welcome the work that's done in this centre and in the health service to deepen our sort of expertise in that area and to continue to improve services for the people of Ireland. Thanks.
Muiris, again, quite a different contribution from this morning, and it puts us into a different place, but really, really interesting and offering some challenges, I think, and maybe you asked a question, and again, was provocative in a way, so might be some responses to that provocation in the audience for a couple of minutes.
Thanks a million for the presentation. It was really, really enjoyable. Just one question, I know there's a provocation in it, but maybe another little bit of provocation as well. And that is, you put up a map of Ireland and the North was missing. And in talking to colleagues in Caught, Western Trust, Altnagelvin, the hospitals up there, and I suppose as academics we have relationships with our colleagues in the North.
Yeah.
And one of the big pressing discussions that's coming out of medical teams in the North and the South and the HSE and other groupings is the whole issue of data.
Yeah.
Where disease doesn't respect borders and boundaries, and I think one of the diagrams you had showed the fuzzy diagrams that kind of applies really to the border as well. My question to you is, as a data nerd, what should we start pooling data as an island in the key healthcare areas that you've gone through? And secondly, is there actually a pathway to do it? Because all we can see left, right and centre is fragmented as you've described. So what can we do to get that island-wide, centralised repositories going? Should it be island-wide? Is that unrealistic in terms of our expectations? Is there actually a pathway to doing that?
Yeah, it's an absolutely brilliant question, and I'm very conscious, and you clearly are yourself, of just what a contribution us in the UK joining, along with Denmark, I think, in 73, 74, joining together and having that regulatory coherence was a huge part of the peace process, kind of in a way I don't think that's been fully recognised. We are absolutely committed to closer and closer North-South cooperation and health in health and in other areas. It has taken a knock through COVID and the Assembly in the North, been 3 years sort of out of action and so forth. But we're absolutely conscious of how vital it is. There's cancer services provided out of Derry for the population of Donegal and Sligo and Leitrim, saving them huge journeys up and down to Galway. That's co-developed by the Irish government and London. There's emergency heart surgeries for infants conducted in Crumlin for all the children of the North. And we absolutely we've had conversations, and between us and our kind of nerdy counterparts, if you want to call them that, totally understand how vital it is, and we're all nervous about deviation and in data standards that might upset data sharing. But also we've pulled in the wider England, Scotland and Wales in more recent times on the digital and data front. And I shouldn't speak this too out loud, but the grand plan is that if the North can maintain interoperability in data standards and technical standards with us in the South, that plugs them into the full 27 European arena, because we'll be observing European. And if they can then be a little bit in their best of both worlds space, if England, Scotland, Wales can sort of not be precious about it and lean, if they can be compatible with the North and the North's compatible with us, then it's great for all island cooperation, and it actually diminishes the potential fallout from Brexit in that space. We haven't delivered that yet. We're working on a refreshed programme. Minister Carol McNeill has met Minister Nesbitt twice now. Their rapport is good, and as officials we have to refresh the programme. But data and digital and deeper cooperation is something we want to. It's a brilliant question. It's a brilliant question, and it's something we have to be vigilant about.
Hi, thanks. A brilliant presentation. It's been really interesting listening all day about the public engagement and stuff. But I wonder, is there just a piece of the puzzle that we're missing? And is it involvement? Is it actually getting the public involved in our projects? Because I think it's great to have the consultations and to be like, it's method A, B and C, what do you think on this? Yeah. But if we had them involved, would we actually be getting method D? That would be even better. And there's just other projects that are going on. For example, down in Cork, the eye clinic and casualty was moved out of CUH and it's been moved into an area that if you have a visual impairment, if you are blind, it is lethal for you to get through. There's steps, there's dark alleyways, there's no, there's no bumps on the road to like kind of direct you that this is where you're meant to go. And I kind of feel like sometimes our public engagement consultations are a little bit like this. The ideas are given, but the method and how to do it isn't always there because we don't actually have the involvement of the people on the ground. So I just wonder, is that something you think that is important, that maybe is the missing piece in some of the things?
Yeah, no, really good question. And like, I think I didn't do justice to particularly the HSE's patient engagement is getting closer and closer to proper involvement, and in sort of working through the design of those regions and the phasing of its rollout, the HSE have patient sort of champions or patient representatives. They provide training to them, and they are at all the tables in the workshops and that. So, but you're right. Sometimes it's done as part of the process, and then the decisions are just taken. Like you say, that doesn't sound like a great set of decisions then for the service in Mallow. So the HSE do much more than I maybe was able to convey in my talk.
Thanks, Muiris. And again, it's an interesting question because, again, going back to the policy handbook, the feasibility piece is one of the questions that arises there. So it's further dialogues, I think, around implementation in the context of policy. That's what it sounds like to me, and overlapping with engagement. I think we probably need to move on and just say thanks to Muiris again for his contribution.